So how can we work out towards predefined tailored protocols for end users to deal with marginal results? So one thing is the purpose of testing. So whether the purpose is to diagnose a clinical case or whether it is not a clinical interest, it is just for the infection control measures. So we have to identify the purpose of testing. And also we have to consider other measures available to mitigate the infection transmission risk if there is any residual potential risk. Sometimes we can't confidently solve all the issues only by testing. So in this marginal zone, sometimes there could be an error range. So then next step is whether we are practicing good infection prevention measures to mitigate that residual potential risk. So that also should be considered in defining these protocols. In places where we can't have such additional measures, we might need to be more careful. In places where we can have a margin of error, then with additional practices for infection control, then we might not need to bother too much about such results. So for all this, we need a proper interaction and dialogue between testing laboratories and end users, means clinical teams and public health teams, to work out protocols. Although I said that we can't have a common CT cutoff for all labs, it is not impossible to have locally validated CT value cutoff for laboratories after working it out with end users for different scenarios with different applications. So it is a process of local validation of your laboratory results with clinical and public health evaluation in the background of that assessment. So that would be the best practice without discarding this marginal zone by default, or without unnecessarily thoroughly engaging in this marginal zone results on each and every marginal zone results. So we have to filter them. So we tend to test different categories of people in community and healthcare setting. In community, we mainly do testing for infection control measures, and there could be some mild symptomatic cases as well, but mainly it is for infection control. Random surveillance or contact tracing before traveling, on arrival, quarantine exit. So all categories are there. So marginal zone results in each category would mean something different. So you might need different tailored protocols in such applications. And in healthcare settings, we mainly test symptomatic cases. So as I said earlier, suspected cases might need a second PCR test if it is highly suspicious. And then the most controversial area is how to screen asymptomatic with regard to how they are asymptomatic and come for some other management into the lab, into the hospital, and we want to screen them for SARS CoV-2 before procedures. So this area in our testing strategy, recently we have suggested to go ahead with antigen test, where you can practice other measures for residual risk, like most of the healthcare workers are fully vaccinated now, and we can practice PPE and other infection control measures. So in that background, the antigen test, which is more predictive of infectivity, would be a suitable test on screening before procedures. But if there are procedures where you can't practice the infection control measures to the maximum, yes, in such procedures, we might be able to do PCR without relying on antigen assay. But in most of the procedures, I think we can do it with antigen test. And when you do a PCR, you might detect a latent infection in a person who have come for some other management, and you might be compromised his other management also, unreliably labeling him as infectious by detecting a late infection in this phase of pandemic with community transmission. Also, we do contact tracing and postmortem samples. So in our authorization, in the lab, medics or consultant tend to authorize results, PCR. So in authorizing marginal results, we have to keep in our mind that sometimes we have identified where we should not make a cross-sectional diagnosis on marginal results. So we have to identify these results. We can't make a cross-sectional diagnosis on the spot based on this marginal results. So you have to identify that. Then we might need to work out whether we need to go for repeat testing of the same sample and whether we want to have a follow-up sample for testing to negotiate this result, depending on its application in the field or in the healthcare setting. So we might need to have relevant comments for the results, which is linked to a tailored end user protocol for application as I described above. And also we need to understand sometimes according to this virus behavior, this is a very peculiar virus. I mean, not like other respiratory viruses or influenza or even the SARS CoV-1. We might not be able to sometimes then and there negotiate or confirm the rule out the infectivity or confirm the infectivity. So there could be a small margin of error sometimes. So that thing should be, the thing is, we have to identify the margin of error without going it unnoticed. So that is the problem. If we do something without knowing the marginal risk, then we might cause troubles. We might give rise to infection transmission risk. But if we can identify the margin of error, and if then we are aware of the margin of error, and then we can see whether that margin of error would be practically having any impact on the setting according to the available other infection control measures. And reporting of CT values is a controversial point again. Some laboratories issue CT values, some laboratories do not issue CT values. In general medical practice, we don't issue CT values because it can be misinterpreted. But in our normal virology practice also, we consider the CT values when we are communicating with clinical teams to make decisions. Although we do not issue it, in our clinical discussions, we consider that CT value because it is having some meaning. Also, although it is not very clear cut. So my impression is that in the pandemic management, we can't have such very close discussion with each and every end user. So CT value would be a good mean of communication about the nature of the result. A CT value of 38, CT value of 18 and a CT value of 33, 34 would mean different impact according to the context. So therefore, I think it is better to issue the CT value in the report, but having the homework done before, like having good interaction with the end users, having good discussions about these CT value issues, and having good comments in place, and also having predefined protocols for different scenarios. In that background, issuing CT values would be very useful for both ends. And it would be considered as a mean of communication, healthy communication between the end user and the laboratory. And they can, if they need any clarification, they can call back and check also. So I would like to suggest in results authorization, now in the beginning we issued results as positive and negative. Then we realized we can't always clearly say it, whether it is positive or negative. Then we introduced the result which is called inconclusive. Now in this prevalence of this outbreak, it seems that we need another category of results, because now we get a very big margin of inconclusives. So in these inconclusive results, we can see some results are towards positive, and we can't say it positive, but it is having more impact if it is positive. And some results we can realize that we can't issue it as negative, but it is more towards with no impact. So I would like to suggest that we might need to have some sort of result format introducing a fourth category in dealing with all these dilemmas. Actually, it is not only my suggestion. I know some overseas laboratories also practicing this concept. They issue results positive, negative, positive at the limit of detection, and inconclusive. So actually this third category, you can put any name. At the moment, I don't use this name because it might be confusing unless having a predefined tailored protocol. Therefore, in this category, I issue results as inconclusive, please repeat. I issue two categories: inconclusive, please repeat; just inconclusive. The just inconclusive I can't give it as negative, but I don't think there would be big impact of that result. But inconclusive, please repeat, I think there could be impact of that result, so need further evaluation. So that's the meaning behind that. So you can put any name, but the concept is having two categories of marginal results for the benefit of application level. Actually, in the recent EQA panel also, I saw they have mentioned presumptive positive. But I have to emphasize that I have seen some reports being issued as presumptive positive without any such comment or predefined protocol. That is also wrong. You can't issue from lab, we can't issue a report as presumptive positive without any clarification. So what the end user should do now? So that is why these all things should come in a package, not as individual components. Then it might be misleading and confusing. So to use these type of categories, we need a good conversation with the end users to have tailored protocols for application. Otherwise, it could be confusing. So the definition for PLOD, so inconclusive, again, as I said earlier, we can have locally validated CT cutoff and also agreed tailored protocols with end user to negotiate these results. That's the way that we can ignore unnecessary results and put some more weight on potential marginal results. And then now you can see in the recent testing strategy, I'm not describing that testing strategy here because it is self-explanatory and it is there. I want to add top of that, so that's why I am going to these details. And you can understand in a central testing protocol you can't include all these things. So therefore, you should consider central testing protocol as a guide, not as a. That doesn't mean you can have tailored ones in your locality. So the idea is based on the central testing protocol to have your own tailored protocols according to the context. But you should not deviate from the concept of the central protocol. So you need to understand the concept of the central protocol. You should not deviate from the concept, but you can have some alterations, options.